All right, thanks, Jordan. Appreciate it. Thanks to the Society of Advanced Body Imaging for hosting the AI Literacy course. Really delighted to be back and participate in this, and wearing a new hat today. So I'll be talking about AI and pediatric radiology. These are my disclosures. Probably a more important disclosure is that, I practice adult radiology for many years and have now moved over to pediatrics. So kind of have a unique perspective on that as an entrepreneur and someone who's made various AI algorithms and taken them through the FDA. So we'll talk about some different things in pediatric radiology here. So we'll review the status of AI in pediatric radiology, describe some key factors for success of AI with pediatric examples, and then discuss plans to revolutionize development of AI for pediatric radiology. So let's first talk about like AI and radiology, kind of comparing peds to adults and just putting things into perspective. So out of the 425 FDA cleared AI solutions in general, about 75% of those are in radiology. So that our field is really ahead of the curve in adopting this technology. Only 7.5% of FDA cleared AI solutions in radiology apply to pediatric radiology. So there's 24 of them that do, and we'll take another look at them. I thought it's just kind of interesting to say that currently to my knowledge, there are 0 generative AI solutions with FDA clearance. And there's kind of 2 reasons for this. The first one is that most of these large language models, especially if they're for dictation or decision support, they don't require FDA clearance currently. So that's one reason. So we're going to see tons of LLMs in our field. It's getting integrated into electronic medical records. And at present, those solutions, if they're not doing imaging or something like that, they're not considered software as a medical device and don't require FDA clearance. So these image-based generative AI that you've seen and ChatGPT and other things like this, those, if you were doing medical images through that would require FDA clearance. And we just haven't seen any of those. So there are groups looking at trying to get this cleared. The pathway is not crystal clear on how to do it. So it'll be very challenging to get the first one through. Most likely the first one through will be on something extremely simple that probably has almost no utility in medicine, but just to pave the pathway. So here's kind of looking at the ACR's website and looking at these. They say there's 26. I combined a couple of these because it's like the same product. I think there's roughly 24 solutions. And the top ones are on the right here in the head and whole body. And so most of the time when a radiologist thinks about head, you're thinking about neuroradiology and these things. In reality, most of these are like dental and things like this. So not really like what you would think about for a neuroradiologist or something. And then the whole body things, these are actually things like for bone and for deep learning image reconstruction. And then from there, it kind of drops off. So not a lot of solutions for pediatric radiology. Just comparing that to adults, the most common are chest. And these are things that look at various abnormalities on x-rays. To the point of the last speaker, they tend to be narrow, so they might do one task, like find a pneumothorax or something like that. There's several for CT that could be detecting lung nodules. There's ones that triage pulmonary emboli. And then there's a bunch of quantification tools, emphysema, interstitial lung disease, et cetera. And the head ones there are more traditional, what a neuroradiologist would wrap their brain around, like intracranial hemorrhage, quantification of various structures, perfusion abnormalities, stroke detection, et cetera. So very big differences between peds and adults. And basically 92% of FDA cleared pediatric radiology AI solutions are for both peds and adults. So I really take that to heart when I think about things that I want to develop, that 92% of these are for both. The only 2 that I see, at least on the ACR website, are for peds only. One is for X-ray bone age, and the other one is for ultrasound developmental dysplasia of the hip. So, and we'll talk about one of these, the one on the left, momentarily. So let's talk about key factors for success of AI in radiology. What really makes something successful? This actually holds true for all of medicine, peds, rad. It doesn't really matter. You want some sort of clinical or research value. And these are usually pretty straightforward. You should be able to explain to a patient. You wouldn't, if they said, what does this AI do? You wouldn't say it prints money. You would say, oh, this algorithm helps me improve detection, or it helps me with increased accuracy, reduce errors, improve triage, improve communication, enhance research in this way. Those are the kind of things that you would answer. Another component is simplicity. How easy is it to integrate the AI? Is it a natural extension of what we're doing in our normal workflows? Hopefully there's minimal training required to use it, and it's a super easy transition to use the solution. And last is a financial benefit. Maybe the AI algorithm creates new revenue. There's very few codes related to AI, but there are other ways to increase revenue. You can also increase radiologist efficiency or increase a patient throughput through like scanners or something like this. So you don't have to have all of these, but conceivably, if you had all of this, that would be a fantastic algorithm, 10 out of 10 score for each of these and an AI scorecard. Probably the most important of these is simplicity. That if there's a perception that it improves clinical or research value, that's actually as or more important than actually improving clinical research value. But that's kind of the key. It's simple and the belief that it's working. In my experience, is all that it really takes to have a successful algorithm. It's nice if you can tie it to some financial benefit. It makes it easier to justify the purchase. We only have so much money, and we have to be able to use it judiciously because of opportunity costs where you could have put the money somewhere else. So let's use as an example, using that framework, AI for X-ray bone age. So I got to see these. We see these every day at St. Jude. So you get an X-ray. It's usually the left hand like this. And the information that is needed for the AI to work is that PA view of the left hand, and you have to specify their gender. And then what the output is bone age in years and months. So it looks at this and kind of compares it. And this is really important if there's a big discrepancy because they treat with that. The user training for something like this, I haven't personally used it, but I'm going to presume that it's pretty minimal, pretty simple. Output's really quite clear what it's doing. Unfortunately, in some multi-institutional trials, the efficiency gain is about 1 minute per exam, actually less than a minute per exam saved. So if you think about it, there's 480 minutes in a day. You'd have to read more than 480 of these things to gain one radiologist day. And you can put a number on that. And you'd have to say, geez, we'd have to have many radiologist days to pay for this algorithm. I do not know what people sell this algorithm for, but typically algorithms are sold somewhere in this $25,000 to $50,000 per algorithm. So you'd have to have quite a few days saved to really justify that. And that really doesn't justify all of it because you have legal looking at it, you have all the install costs, all the time of informatics reviewing this, information security reviewing this, et cetera, to justify the use of this algorithm. So the clinical or research value is improved inter-observer agreement. The AI is going to be more consistent than a group of radiologists, and some improved accuracy, especially for non-experts. Do we typically buy things because we are buying it for non-experts? Not really, but that's kind of where I see the clinical or research value. So it seems super simple to use. I haven't personally used this, but let's assume that it is. And I would say the financial benefit is negative, meaning you will lose money buying this algorithm. It's due to the cost of the install and other product fees, and I just don't know that you're going to gain enough of this unless even if you're doing 10 of these a day. It's kind of it's curious to know if that is enough to justify the cost of this. We don't have to buy it because of cost. You may still choose to get this algorithm, but so if I was giving this a score, pretty low clinical or research value. It has some value, but it's not doing amazing things there. And because honestly, you can do this task without it. Simplicity is very high, maybe an 8 or 9. And the financial benefit, if I could put a negative number here, I would, but I didn't have, my scale was from 1 to 10. All right, let's talk about this, deep learning image reconstruction. There's several different forms of this. This is really helpful, okay? So imagine that you're doing a CT scan with low MA, and you're going to get noisy looking images, and you're trying to find a tumor. The tumor's name is Waldo in this case. So this is a classic, where is Waldo? Where is Waldo in this? It's kind of hard to find Waldo because of all that image noise. You can use deep learning image reconstruction, or DLIR, and then obtain a high quality image by pulling that noise off. The intensity values don't actually change in this particular case if it was CT scans. And that's what you get. So this is where Waldo is, very easy to find, relatively speaking, on this image. Here he was on the image for low quality, where there was low MA and all this high noise. If you had removed the noise, which is what we did, you could have found him a lot easier. Now, we'll look at some actual CTs. It's not this dramatic. This is meant to sort of sensationalize it a little bit, but the improvements are not that dramatic, although I do think they're important. So if you did a high dose scan, or full dose scan, you would get a beautiful looking image, the apices of this lung. If you did a low dose scan, we don't do lung cancer screening like this that often in pediatrics. There are some times where you do, but it's less common than adults. it'd be very hard to find the lung nodule in this because of the noise. Now, you can go really low dose, you want to in pediatrics, but you can take it too far just as you can in adults. And here you wouldn't be able to find this particular lung nodule unless you had deep learning image reconstruction, pulling out the image noise. So the image on the far right in blue is not the same one as the one on the far left. This is using deep learning, pulling out that noise off of the purple one, and then you could find this lung nodule if you had these higher quality images. So there are conceivably times where this could happen. Probably would be most useful, yeah, if you're taking things almost too far, like the purple image is going too far with your dose reduction techniques in an attempt to where you maybe overvalue low dose over making a diagnosis, but you can make up for that with a high image quality. This here, there's no AI on these images. This is just one single scan, a non-contrast scan through roughly the liver, upper abdomen. And you can reconstruct it at 2.5 millimeter on the left, pretty common reconstruction. Some people use 5 millimeter. And on the right, 0.625. By the very nature of it, you're going to have higher noise on an image that is thinner slice. And so how could you get rid of that? You could use deep learning image reconstruction on that thin slice image and kind of compare these. Which one has lower noise now? Remember, it's not actually about noise that matters. What really matters is, do we make more diagnoses? But the reality is we have done this at St. Jude, changed all of our protocols, implemented deep learning image reconstruction on thick and thin slices, and it has dramatically improved our quality, allowing us to then make choices. Do we want to reduce our radiation dose 25%? Maybe only 10 or 15%, and then have a balance between improved quality of scan. So I'm tending to split that difference, reduce the radiation dose a little, but also achieve higher image quality, particularly for the thin slice. So now we're able to look at things with thinner slices and higher quality. And by the way, these algorithms sometimes are specific to a certain type of window. So for example, it'll work on soft tissues. Now I can change the window settings and still look at the bones and the lungs, but it's not with that not that type of a kernel that can be used. So and in this particular vendor, I can't do a bone kernel or a sharp kernel and then apply this algorithm. Those things will come with time. I'm just telling you right now, it tends to be a bit body dominant for a typical smooth algorithm that would be used for body imaging. Here's a classic pediatric patient. This is exactly what people are used to looking at for many years, especially if you wanted to go thin slice. And here you could look at an improved quality image. This is what we are now looking at St. Jude. Higher quality imaging, easier to make diagnoses. I don't know how much improvement we're going to see. And when I read the literature, maybe a couple percentage points of improved detection of low contrast structures. So we're not always looking for low contrast. So overall scans is probably a relatively small effect, but I do think that there is a real effect there where you can see things better and reduce potentially diagnostic errors. So the clinical or research value is improved image quality, perhaps improvement in detection of findings by a smidge, and lower radiation dose, which really matters. Pediatrics, it's about 4 or 5 times the risk of radiation causing a downstream event like a cancer or something like that, particularly if they're going to get repeat CT scans. Simplicity, it's actually intermediate difficulty to deploy. I have learned this by actually doing it, and it's kind of harder than you think. You don't just say, turn it on all the CT scans. So if you have a vendor-specific solution, like on the actual scanner, you have to do on each and every single protocol and carefully apply this. And that is really difficult. You might even want to change the name of your series to reflect it. And I also find it sort of difficult to operationalize that. Just to roll this out has been a challenge. I do think that we can do this in months, not years, but it really depends on the size of your CT fleet and how you're doing this. There are also vendor agnostic solutions that do this, but also those typically require certain types of inputs, so you're not going to get around it. You're going to have to change all of your protocols one by one. In an adult world, you might have hundreds of protocols on a scanner. In a pediatric world, there's usually not hundreds, maybe dozens or so that you might need to change, so still pretty difficult. Financial benefit, pretty minimal. I mean, it's possible you could say, well, our tube might last longer if we, use less radiation, this kind of thing. It might improve radiologist efficiency by a teeny smidge. It's possible there's some financial benefit there, but not a big financial benefit. So I'd score this as like intermediate clinical or research value. It's pretty simple in terms of conceptually, but rolling it out is not that simple. So maybe a 5, and the financial benefit's pretty low, around a 2. That said, we're using it. We like it. This is one that I like and think is worthwhile having. Let's talk about it in PET, about deep learning image reconstruction for PET image. So what do you need to get a good PET scan in adults or pediatrics, honestly? You need a full dose. Let's say it's 10 millicuries. We're just going to use that as a simple number. And you need a full scan time. Let's say that's 20 minutes. So what happens if you cut your dose down to a quarter of that, just 2.5 millicurie? You're going to get noisy looking images. Conversely, you could have done the same thing, had a full dose, but 1/4 the scan time, 5 minutes, and you would have sub-quality images due to high image noise. So you can use deep learning image reconstruction to get this back. This is another one that we have deployed at St. Jude, and it has been a big help to us. And you can make choices. You can decide some patients can't hold still very well. Maybe you'd focus more on reducing their scan time. Sedation is an issue in children. So can we avoid sedation by doing this and having faster scan times? On the other side of it, if you have an older child and you're doing lymphoma, something you don't want to just contribute more radiation to them. If they're in the cure zone where we're just kind of tracing them or following them over time, you might choose, in other words, to reduce radiation. Or you can do a combination of the both of these things. So this is another winner for us. A little bit different value proposition. So you could do the 5-minute scan and higher throughput and increase patient satisfaction, maybe reduce sedation. You could also do the quarter dose of radiation, which lowers exposure to young patients. And that, honestly, this ability to reduce the noise would open up potentially new opportunities, improve signal to noise for experimental radio tracers that just can't put out enough radiation to get a clean image, when you might be able to get that clean image by having the deep learning image reconstruction. So we think that this can increase patient satisfaction, faster scans, better scan quality, reduce radiation dose, as we said, potentially reduce some sedation cases. How simple is it? It's relatively easy to deploy in a scanner. You don't typically have tons of different body protocols on a scanner. So that's pretty easy to do, maybe mildly difficult to operationalize. If your goal was to scan more patients, do you have enough uptake rooms to be able to do that? Do you have the personnel to be able to handle that? So you might not be able to quadruple the number of patients you do on a scanner. That's probably unrealistic. But sometimes just getting in 25% more scans in a day could be a huge benefit for you. So the financial benefits, the faster scan and the higher throughput. So I think the financial benefits score would be a bit higher in this one. So clinical or research value, maybe a 5, maybe a 6, somewhere in there. Simplicity, it's definitely easier to do than the CT. And we typically don't have as many PET scanners as CT scanners. And there is some financial benefit to this, putting more patients through it. It's that maybe even avoiding the sedation from the patient's perspective, et cetera. Let's move on to MRI. So this is probably not a realistic academic MRI where there are 7 series here, but you could imagine one. Typically, they're much more than this, particularly for body and even for neuro. MSK maybe has 7. They're on top of keeping their number of series down. And each sequence requires a different amount of time to be able to do that. Let's just say that the total exam's 25 minutes. With deep learning image reconstruction, you can shrink that down. I tried to represent it in the picture here that some series will be affected more than others, some not at all. Maybe it doesn't apply to that. That is particularly true for vendor-specific solutions that are part of the MRI purchase that you've done. That particular vendor may have a solution. In our experience, some of those, we have one of those, and it doesn't affect any of the body protocols, but it does affect some of the neuro sequences. So here's just an example, a conventional MRI T2 weighted axial brain image. On the left, the conventional 130 seconds, on the right, 80 seconds. So not quite cut in half in time. I mean, realistic numbers are probably to shorten maybe an entire protocol by 20 to 50%. 50 on the high end would be tough to achieve, 25% usually achievable, particularly in neuro and MSK. I think body lagging a little bit, just these algorithms don't seem to apply as much to abdomen and pelvis. Here's just a sagittal T1, 270 seconds conventional, 170 seconds deep learning. So we didn't cut it in half, but certainly more than 25%, somewhere between there. And this can apply to different things. There's a flare, you can do it on diffusion weighted, you can do it in different body regions, the spine, musculoskeletal, some body, again, not the one that I have that's vendor specific, but there are vendor neutral ways to do this. So it applies to multiple series types, but not all. I wanted to stress that. Radiology departments can continue to use their normal sequences. They usually turn up the acceleration to get the sequences done faster. The penalty for that is noise. The deep learning cleans up the noise. And there are vendor-specific and agnostic solutions. We are trying to exhaust our vendor-specific one just because we have it, but now we're already saying this is not enough, particularly for the chest, abdomen, pelvis MRIs that we're doing. And so we're looking at vendor neutral solutions. And users can choose to decrease time or potentially increase signal or resolution. And that's kind of true between a 1.5 and a 3.0 Tesla. You actually could do a faster scan on the 3 Tesla if you were just trying to achieve the same quality as a 1.5. In our field, for some reason, we always want to have more and more and more information. So you have to make these kind of tough choices. It depends on the patient. What kind of an exam? I got asked by a vendor one time, well, what are you trying to achieve? I said, how about a 5-second MRI? I mean, that's what I want. I want to just get on it, and in 5 seconds, one breath hold, I'm done. So we're a long ways away from a 5-second MRI, but 5 minutes, maybe 10 minutes, it could be achievable, especially if you're really judicious about what series and sequences and so forth you're choosing. So here's an example image with DWI. And again, I think this is kind of a realistic number. Moving from 25 to 15 could be done with some effort. This can increase patient satisfaction, reduce motion, new opportunities in research for MRI, and really one that I'm really trying to do. I want to get this down. This is why I want a 5-second MRI, is I want to get rid of the sedation. We have a lot of sedation in under 10-year-olds, and this is one way to potentially get there. So this is a very high priority for us. As we launch this project, it's going to take a year. I would say a year's worth of effort of an entire team to figure out how to do this across most of our sequences. So this takes an entire team to be able to deploy this. That's why the simplicity factor is not particularly high. Great solution, difficult to deploy and operationalize. And then this faster scan used to higher throughput. Okay, that's good from a financial standpoint, I'll admit it, but it's like I said up above, it's also good for clinical value for the patient. I think that being faster, you don't have to convert this to, hey, we were doing 20 scans a day. I'm just making up a number on this particular scanner, and now we're going to do 30 or something. You don't necessarily have to do that. You can reduce tech burden, help reduce their burnout. I mean, they're short of staff. They're getting burnt out as well. And having these faster scans gives them some breathing room. Our techs talk to us about that and appreciate that. So the clinical value is pretty high here, maybe an 8. Simplicity is really low. It's very difficult to do this. I'd say a 3, and then there's a financial benefit to this. It's hard to operationalize or capitalize on that financial benefit, but you could if you wanted to get more patients through if that was your goal. All right, let's talk about large language models in radiology. Unfortunately, this is an adult report just because I saved it from there, but this is, pretend I've dictated a big report, whether it's PEDS or whatever. This happens to be HCC follow-up, and there's some treated lesions, 2 of them. There's 2 untreated lesions, all kinds of like classification, tons of information in here. And the point is you can just hit a button or activate a large language model. A couple different vendors now have this. Sometimes it's in a widget, sometimes it's contained in the dictation system, and it will summarize the report. It's not always right. Most of the time it is correct. And I think that this reduces our cognitive burden. I came from an institution that had it, moved to an institution that didn't. And I'm like, where's that thing that thinks for me? I wish I had that again. So I don't know that it really improves efficiency as much as people would like you to think. So I'll show you a graph here, report time on the y-axis. The more words you have, the large language model makes this particular reader faster. And I think this is one reader, and it probably is the one in your group that got the most benefit from it. Think of it that way. Some of us don't benefit from the speed as much. This applies to multiple different modalities. I've seen it as a widget, and now I'm seeing it as an integrated solution in the dictation system. Requires minimal training, super easy to use. There's some time savings. I'm going to describe it as minimal. Other people say it's more. I think if you're in a private practice setting and dictating on your own, you're probably going to achieve more benefit from it than if you're in academics and having this extremely wonderful tool known as residents and fellows, which are much better at summarizing reports, in my opinion, than the AI. The clinical value, maybe it reduces. I've had it help me reduce some right or left errors, maybe 2 the entire time I used it. It reduces some cognitive load and burnout for sure. And that's really important from a clinical value perspective. It's pretty easy to integrate and easy to use. Probably one of the easiest AI solutions that I have seen. It improves radiologist efficiency to some degree. Not really clear on how much, depends on your practice pattern, how you like to dictate. Do you even have an impression for some of these? And maybe it improves recruitment, retention. I don't know. I liked it. I know when it gets turned off, people complain, so they clearly like it. So this clinical or research value is really low. The simplicity is really high, and I think there's some financial benefit to this. So I think it's a reasonable algorithm to have. We liked it a lot, and I would probably get something like this again here. I'll probably try to institute this at St. Jude. Let's talk about some barriers to development of pediatric AI. A lot of people say the barrier is, oh, there's just not enough image. That is not true. There are plenty of pediatric images out there. What is true is the market size of pediatrics is just roughly, I'm just taking a guess, 30 times smaller than adults. And so that market is a driver of commercialization. People want to go where the markets are bigger. And then honestly, if you think about it, there's probably a lot less data scientists working on pediatric solutions than adult. There are probably, tenfold number of people working on adult solutions, partly because of the market size, but there's just more radiology departments focused on adult. So that's part of it, is market size, workforce size. And then just in general, our data is kind of locked up, particularly children's hospitals are like holding on to this really tight and worried about it because of rare diseases and other reasons. So there are reasons for it, but they're holding on it a bit too tightly, in my opinion, and probably need to learn to release that. So how can we revolutionize development of AI for pediatric radiology? One thing that I'm proposing is this. Is a multi-institutional consortium, and this one's called Artificial Intelligence, Multi-Institutional and Exploratory Research. Shorthand is AI Miner. You're mining for images to make AI, and it's a consortium, a group of institutions working together. So this consortium could include pediatric and adult medical centers collaborating with each other and with industry partners to develop innovative and ethical AI solutions that enhance research and patient care. So this is kind of what I think it could look like. We're asking people to free their minds being these siloed packs that don't communicate with each other. So bring a consortium together. I think it should have peds and adults. Did we not just see that most algorithms that are successful are in both peds and adults? So I think we need to bring them together, get an IRB in place, get some legal documentation in place. Then we start mining. We deliver software to groups to help them curate, de-identify, and transfer their images. These will be for individual projects and possibly even big data projects. We can find ways to transfer images securely and store them. It's not just about sticking them in a safe. You want to organize that data. You want to have AI that classifies series, that you pull out DICOM header information, associate it with the anonymized reports, et cetera. And then that's going to allow us to build strong AI, whether it's deep learning, machine learning, generative AI, and even foundational models are possible to build. I'm not talking about ChatGPT size models, but you can build even some simple foundational models on a single GPU card. And if we work with industry, academics, industrial partnership, we can get some of these things FDA cleared. To me, this is how you revolutionize pediatric radiology, is you work together, including with our adult partners. So how do you do this ethically? Just quickly, it can be done. Everything's research. All of it has objective hypothesis. Get it IRB approved. We already have an IRB for this. Securely and use encryption to do your data transfer and storage. And because of that, you can wrap this in a HIPAA compliant process, and then you get a waiver of consent for this. We want diverse data from all over the place, multiple institutions. We use team science and pull a bunch of the greatest minds together from the peds and adult worlds. Use strong data governance for rules of how the data can be distributed, and you need some fair access to it. We're proposing some things like credits. You put in images, you get certain credits and can pull images back out of the system. So I think this can be done, and we're in the process of trying to launch this. So that's AI Miner. If you're interested in it, my email is at the bottom, andrew.smith@stjude.org. And I'll just move on to a couple more topics to keep us not too far off of time. How about upcoming solutions, AI solutions in pediatric radiology? I think it should be fairly easy to achieve body composition analysis on CT and MRI. And you can do it for peds and adults, okay? Some people have already done this for adults. You could apply this, if you had this algorithm, to all past and future exams. Not even saying this has to be FDA cleared, because I think it has high research value potentially to do this across different trials. Think about it in cancer trials and other things. This can even influence the choice of drug you have or the outcome of the drug. This can be fully automated, and I think it increases grant opportunity. So I think it gets a fairly good score here across the board, something to be useful in pediatrics. A couple other things is we've done this in adults where we use AI for advanced cancer and pediatrics to segment tumors and measure them on CT and MRI. So how about we create this for peds? I mean, if we've already done it in adults, how hard can it be to do it in peds? I think it's achievable. And we would incorporate the AI into viewers' reporting systems, possibly into PACS to be able to do this. Doing this reduces errors, it improves accuracy, and you can even do programming to standardize cancer response. It does require user training and effort to operationalize this. You wouldn't want, if you had 20 radiologists doing this, 2 of them say, I'm not going to use it. Everybody kind of has to buy in on this kind of a technology. And then you can generate income from trials and increased radiologist efficiency. If we're able to do this, to me, this is a very high algorithm, a high value algorithm, both for clinical research. It's not super simple because you have to deploy it and people have to learn to use it, but it has a tremendous financial benefit. A couple other things. Just putting them all together. Can we make AI that detects lung nodules in pediatrics? Sure, we can. It's not been done, but we can do it. What about pathologic lymph nodes? That hasn't been done in adults, but it could be done for peds and adults. I think even bone metastases is possible in peds, probably even easier than adults because they don't have the degenerative changes that could probably fool an AI algorithm like we would in adults. And again, you could apply this forwards, backwards, whatever. Some of these could get FDA cleared. I think they'll improve detection, increase measurement accuracy. They could be fully automated, and they can improve radiologist efficiency, open up grant opportunities. So scoring maybe like a clinical value of 4, simplicity 8, financial benefit of like 5, intermediate. One last one, I've asked some of the leaders in the field at Scorch, where all the chiefs and chairs were, who wants to have an LLM for patient and family-friendly report summaries. So we saw that it can already summarize in clinical jargon. Why not summarize that same thing in patient and family-friendly language and reducing these complex medical terms into something they can understand? So it would translate the jargon into plain language, providing clear and concise summaries for diagnosis, treatments, plans, follow-up instructions. This can go beyond radiology reporting, but we can certainly think of it for that as well. So this would allow patients and their families to have improved understanding, enhance their engagement, improve clinical adherence to things if they can understand the language, particularly if it's in another language. This is potentially very easy to integrate and easy to use. That doesn't mean it's easy to make the AI algorithm, but I think once it's made, those things can be done. I think the financial benefits are a little bit lower here. Like maybe patient satisfaction scores go up a little bit. I'm worried it's going to decrease radiology efficiency, so we have to find out how to do this as the fastest way to deploy it, but also safe. And I have my own thoughts on that, but this is kind of team science world. We'll figure out how to do this together. So I think the clinical and research value is high, the simplicity side, the financial benefit is on the lower side for this. Patients want this. A lot of radiologists that are in pediatrics want this too. So we covered a couple things in this on AI and pediatric radiology. We said about 92% of FDA cleared algorithms were for peds and adults. That's a message. We need to hear the message. We talked about key success, areas for success, having a clinical research value, simplicity, and a financial benefit, simplicity being the most important. We looked at AI for bone age, and it has some benefits, but is a big-time financial loser, in my opinion. Deep learning image reconstruction was a win. Deep learning image reconstruction for CT, for PET here, was also a win, and also for MRI as a win. So those are big for pediatrics. LLMs to generate report impressions is also a win. The barrier to pediatric AI in pediatrics was market size is a problem. The pediatric market is too small, and our data is siloed, so we proposed AI Minor. If you wanted to join that, please let me know. And the last one's things that we can make in the future: body composition analysis on CT and MRI, AI that segments tumors, automated detection of various tumors, and even a large language model for patient and family-friendly report summaries. So I'm a few minutes over, but I thank you for the opportunity to present.
And Dr. Smith, thank you so much for such a great presentation. That was really fantastic, a great overview of where we are in the marketplace, also in AI and pediatric imaging. So again, if there are any questions, please feel free to put these in the Q&A. But I did want to ask, with this perspective you have on seeing adult-oriented AI tools and then being on the pediatric side, what do you feel like would be maybe the biggest bang for your buck adult AI tool that you could bring into pediatric imaging?
Yeah, that one's tough. I'm actually doing it the other way, which is what is the easiest to make, which is not necessarily how you should do things, but translating to a new world. So body comp, easy to make. I'm just going to go ahead and do it, just because I think I can make it, get it FDA cleared if I need to. I don't think it's trivial to do the patient and family friendly reports. Even some of the experts in our field, I was just listening to a talk and they're like, this is not achievable. I do think it's achievable. I think that will have a pretty big bang for the buck. It's not a money winner, but it's a win for patients and their families. So it's going to be high on our priority list to be able to do that one. And it doesn't require necessarily FDA clearance at this point based on the rules. It's not generating or looking at images, it's just summarizing text. So I'm going to go for that one as my, achievable and high value.
Yeah, definitely. And that addresses a question that we had yesterday that we uh, had in the QA or the Q&A, a question about how large language models, generative AI, can be used in radiology AI. And that's a great example of a relatively simple, relatively low investment way to be able to use, leverage some of these existing tools in a way that's specific and impactful in radiology. And, of course, you have to have some quality checks built in there and make sure that you're not having any hallucinations or anything that's being mistranslated that you come out and end up with, ideally everything is concordant, but you don't have anything that's completely off of what you're trying to communicate. But yeah, no, just a great example of how that can be applied in creative ways. But yeah, so for Dr. Mandel, if you're still on, we do have one question in the chat for you regarding AI and MSK imaging. We have a question regarding the most useful metrics for evaluating the diagnostic utility of some of these AI MSK tools. So when you're looking at these clinical tools, are you looking at accuracy, sensitivity, specificity, AUC for some of these comparison studies? So what do you feel like is the most meaningful?
Yeah, that's a great question. I honestly have no idea how to answer because it's such a good question. It's a very deep question, and each of these tools is kind of evaluated differently. So for our project that we did about hand x-rays, we just provided AUC, and we didn't provide sensitivity and specificity because to determine osteoarthritis versus rheumatoid arthritis, there's no real right answer. So we use the kind of radiologist, the two MSK radiologists or a third if there was a disagreement to make the ground truth. So we didn't really have an expert read our sensitivity and specificity. For other things, especially if there's like a real ground truth, like surgical or pathological correlation, then you can measure sensitivity and specificity compared to radiologists of various experiences, which is how I think most of the literature has been reported. So for instance, in the complex model example from Wisconsin, from Kajowski, in that group, they use radiology residents, a senior MSK radiologists, and radiology fellows. So it really depends on the model and the data and what's being reported.
That's great. I think that's a very good nuanced answer. Well, so that concludes our second day of the AI literacy course. We are going to be back tomorrow with lectures on AI and cardiac imaging and a introduction to radiomics. So a very full day tomorrow as well. As a reminder to everyone, we will have these lectures recorded and available on our YouTube page 1 to 2 weeks after we finish up with the course. We'll send out that email to everyone who's registered with the course after we conclude on Friday. And we will look forward to seeing you all back tomorrow. And thank you again to Dr. Mandel and Dr. Smith for 2 excellent lectures today. Thank you so much for your time.
Yeah. Thank you for listening, and thanks for the invitation.
Yes, thank you. Enjoyed it.